Okay, welcome everyone to today's session of our Now educational webinars. Today's topic will be on glioblastomas. This program is hosted by the Blum Resource Center. Over at the Blum, we are grateful to the Now team for this continued partnership. The recording of this session will be posted on our Blum YouTube playlist and our Blum Digital Resource Center. For those of you watching live, if you have any questions related to today's program, please feel free to utilize the Q&A feature throughout the session. At the end of the session, your questions in the chat will be used to moderate the Q&A. If you have any other questions or would like more information about resources and programs offered through the Blum, please visit us at www.dana-farber.org/resource center or email us at blum_center@dfci.harvard.edu. Thank you all for being here. I will now pass the workshop over to Dr. Gonzalez Castro to introduce our panelist.
Thank you, Sierra, and good afternoon, everyone. Thank you for joining us today for a new Neuro-Oncology Wellness Education webinar. As you know, the Neuro-Oncology Wellness Program is an initiative from the Center for Neuro-Oncology here at Dana-Farber with a mission to educate patients and their caregivers about brain tumors, as well as to provide resources to promote overall health and well-being. My name is Nick Gonzalez Castro. I'm one of the neuro-oncologists here, and I serve as director of the NOW program. Thank you for joining us. We want you to be part of this conversation by submitting your questions via the Q&A feature at the bottom of your Zoom screen. And note that we will select a number of questions, as many as we can, for our guests today to answer in the second half of the program. We're in for a real treat today, as we have our colleague, Dr. David Reardon, who is joining us for a discussion on the diagnosis and management and research promise on glioblastoma. And it is now my pleasure to introduce our guest today, Dr. David Reardon. Dr. Reardon is the Alperin Family Chair in Neuro-Oncology, Clinical Director of the Center of Neuro-Oncology here at the Dana-Farber Cancer Institute, and Professor of Medicine at Harvard Medical School. Dr. Reardon is the recipient of numerous awards. He's the past president of the Society for Neuro-Oncology, which is the main society in our field. And most importantly, he has been caring for brain tumor patients for over 25 years. His research career has been devoted to finding more effective treatments for patients with primary brain tumors, including glioblastoma, and he has led multiple clinical trials evaluating immunotherapy and other therapies for the treatment of glioblastoma. And in the immunotherapy field, he's been very active on the use of immune checkpoint inhibitors and cancer vaccines for glioblastoma, and we'll get into some of that work later today. David, thank you so much for joining us today.
My pleasure, Dr. Gonzalez Castro. Thank you for putting this important program together.
Thank you so much. I think that we are revisiting a conversation we had about 2 years ago, and there'll be new content to go over today. But I always think it's important to start at the beginning and help guide patients and caregivers who perhaps are new to this disease. So can you give us a general overview of glioblastoma? What is this tumor? How common is it? And who is most commonly affected?
Sure. Obviously, that's, I agree, a very important foundation and framework to start from. Glioblastoma is the most common type of malignant tumor that arises in the brain in adult patients. In the United States, there are approximately 13,000 cases diagnosed per year. It is a cancer that can happen at any age. Unfortunately, we've cared for young infants and children, adolescents, and adults of all ages. It does increase in frequency as we get older. So the most common patients in our clinic with this diagnosis are in typically their 6th or 7th decade of life. Like many cancers, it's modestly more prominent in men than women, but we certainly have many female patients as well as our male patients, of course. A lot of research has been and continues to be committed to understanding why these tumors develop in our patients. And so far, with rare exception, there does not seem to be a tie or a link associating the development of this cancer with something environmental, something that a patient was exposed to, an infection or a chemical agent or a head trauma. That's been something that's been looked at. And on the flip side, there's also a lot of research and interest in identifying if glioblastoma tends to run in families. In other words, is there an inherited or a genetic predisposition? And fortunately, although that can happen, that's quite rare. And for the vast majority of our patients, there is not anything that is related to an inherited or genetic risk. In other words, their immediate family members, their brothers, sisters, and children are essentially at the same risk as anybody else in the general population for having this happen to them. And on the other side of the coin, there is not anything that our patients have done or been exposed to that caused this to happen. As best as we understand, like many cancers, unfortunately, just bad luck for the development of this type of cancer. This is considered one of the more difficult to treat cancers in medical oncology today. We've made tremendous strides in better understanding the biology of these tumors, why they grow the way they grow, what gives them a growth advantage relative to normal cells in the body. And your lab, Dr. Gonzalez Castro, is doing a lot of terrific work in better understanding these features. And what we're trying to do now is put those pieces of the puzzle together and link them with treatments that may have a better likelihood of working. In other words, if we understand better why these tumors behave the way they do, we may be able to design and implement treatments that may be able to have a better level of success and effectiveness. So that's a main area of ongoing research in my work. As you mentioned, Dr. Gonzalez Castro focuses a lot on the immune system, our body's natural defenses, to try to be able to sensitize against the tumor and successfully attack it.
Thank you for that wonderful overview. Very helpful for patients to understand the whole landscape of the epidemiology and risk factors. And, just walking through, a general scenario that we might encounter. Last month, we had our first webinar of this year, and we discussed brain tumor symptoms and seizures and headaches. And some glioblastoma patients present with these. They're often, brought into the emergency department. There's some imaging that shows a brain lesion. What are the next steps after that? What do we do to establish a diagnosis?
Well, that's a critical next step. Patients typically develop symptoms related to the tumor impacting the normal function of the brain. And sometimes that can lead to what we refer to as focal neurologic deficits. In other words, a part of the body that's not working or functioning properly. It may be weakness. It could be difficulty speaking or articulating, saying what you want to say. If it's involving that area of the brain, it could involve changes in vision if it affects those parts of the brain. So very much related to the anatomy of where the tumor is arising in the brain typically can develop or lead to these associated symptoms. And very importantly, and in some patients, I did want to mention either seizures or headache, as you mentioned, could be the presenting factor leading to a diagnosis or coming in to get assessed. The headaches that typically evolve are usually very different than the common routine run-of-the-mill headaches we all deal with and experience. These tend to be headaches that occur regularly and frequently and get worse and worse over time, happening more frequently, lasting longer, having more discomfort and being having associated pain and discomfort that worsens over time. So when a patient comes in, they have typically the MRI scan is the best way, the state-of-the-art capability now to evaluate the brain and look for what may be causing these neurologic symptoms or issues. And what we see on the MRI scan is usually a mass, an area that doesn't belong there that we see on the MRI involving a normal component or area of the brain. The next step is typically evaluating whether that can be safely either biopsied or removed, ideally. Removing the tumor with our skilled um, neurosurgical colleagues is critical because it not only removes the mass and can alleviate some of the pressure and symptoms, but it also gives us tumor material then to take to the lab and study in detail to understand what exactly that mass represents. In our patients, it ends up being findings consistent with glioblastoma when we study it under the microscope. And then more importantly, nowadays, or increasingly importantly nowadays, understanding the genetic blueprint of those tumor cells, what's abnormal, and giving the tumor cells a growth advantage that we now have technology and capabilities of being able to dissect out at a remarkable level that we simply didn't have 5 to 10 years ago. So we have all of those fantastic state-of-the-art technology and tools to be able to take a deep dive, if you will, into analyzing that patient's tumor. But the critical first step is removing the mass. And then once the diagnosis is established, we typically convene a multidisciplinary team with our oncology colleagues, our neurology colleagues, our radiation therapy colleagues, in addition to our neurosurgical colleagues, to sit down together case by case and make a plan of how best to move forward with treatment for that patient.
Thank you for explaining all that. As you mentioned, surgery is critical as it helps our patients. It's a first step in treatment and helps establish a diagnosis. Uh, it's important to note as well, despite the tremendous skill that our neurosurgical colleagues have, that this is an infiltrating tumor and cannot be removed completely. So as you mentioned, we meet and discuss every case and decide what is the best next step in terms of treatment. What are some of the standard treatments that we discuss with our patients when they come for that post-surgical follow-up visit?
Yeah, that's a critical point. But I did want to emphasize one thing that you did allude to there, Dr. Gonzalez Castro, and that is the infiltrative nature of this type of cancer. This type of cancer, for reasons we don't understand, and this is an area where research is being done, does not metastasize. In other words, it doesn't spread. It originates in the brain and then it stays there. In my 25 plus years of caring for these patients, I think I've had maybe one or two very, very rare exceptional cases where we've ever found the tumor outside of the brain. And what it does instead to make up for that lack of spreading in the body is that it infiltrates and moves outward. So we have the main mass of the tumor, but all around the perimeter of that are these microscopic cells that are blending right in with the adjacent brain cells and normal cells, and they're little by little moving outward and taking over those adjacent areas as they spread outward. And that's what ultimately will cause more neurologic deficits, more difficulty, more pressure, and ultimately, if not treated, a patient will die from that process. So once the main mass of the tumor is successfully removed, that removes the mass, but we still have to tackle these infiltrative cells, and that's why surgery is a critical first step, but unfortunately it's not a curative step. We still have to follow that up with additional treatment to begin to tackle these microscopic cells and try to prevent them from growing and dividing and causing the mass to come back. And the treatments we've relied historically on, which have the best proven track record of treatment, is very carefully delivered radiation therapy to the area around where the tumor was resected. And radiation therapy works by killing cells as they're trying to grow and divide. In other words, they can't split into two and cause daughter cells to populate. So that's a very effective treatment in the area where it can be targeted. And then we also have typically relied on the addition of chemotherapy, specifically a drug temozolomide or Temodar, And chemotherapy drugs like Timitar are essentially glorified poisons. They kill cells that are trying to divide and grow. And because cancer cells grow at a much more dysregulated or rapid rate than normal cells in the body, they are preferentially susceptible to chemotherapy drugs. And that, in addition to the radiation, is the cornerstone of what we typically utilize for patients going forward after surgery. The radiation therapy is typically given Monday through Friday for 3 to 6 weeks. In some of our older patients who are having a more difficulty, a 3-week course can be just as effective, but safer and better tolerated. But our younger patients or patients in pretty good health and shape going into this, we typically give the radiation Monday through Friday for 6 weeks in order to continue to administer these fractions of treatment in a way that cumulatively will have the best effect on trying to kill the tumor cells. And over those 6 weeks, we use the our standard treatment involves using the chemotherapy drug temozolomide because that acts kind of like a 1-2 punch where the chemotherapy can sensitize the tumor cells to be more vulnerable, if you will, to the effect of treatment, and allow a higher percentage of the cells to be able to be killed. After the 6 weeks of radiation with daily chemotherapy is done, we typically administer additional chemotherapy over 6 months, 5 days in a row each month. So the total duration of treatment after surgery, the 6 weeks of radiation, usually a 4-week break, and then an additional 6 months of chemotherapy, typically takes about 8 to 9 months for most patients to complete. In some patients, if the tumor is continuing to shrink and they're responding and tolerating well, we may continue the chemotherapy for additional 3 to 6 months after finishing the first 6 months of treatment. But that's more of an exception rather than the rule. I tell all my patients and families these treatments, what is established as our standard of care, our gold standard of treatment, does help most patients. There's unfortunately a subset where even this aggressive combination of radiation and chemotherapy doesn't work, but that's more of a minority and an exception of patients. For most, the tumor will initially respond. The problem we have with these therapies and our standard therapies is the durability of their benefit and how long they last. And unfortunately, either during the treatment or after the treatment has been completed, the tumor is able to regroup, realign, and come back. And when it comes back, that's an indicator the treatment is no longer working, and we need to think about alternative treatments and approaches to try to get things back on track.
Thank you for describing very clearly what are the main standard therapies that we have available and we discuss with our patients. I wonder if you could mention a few things about tumor treating fields, which is another available treatment that sometimes some of our patients decide to incorporate along with adjuvant temozolomide.
Yeah, thank you for that. That's an important point. The tumor treating fields we call TTF or Optune is applied directly to the scalp, and it generates a high frequency oscillating electric field. Patients don't feel anything, but with this device applied to the scalp, and it is connected to a small 3-pound battery pack that provides the energy. This generates in targeting the area where the tumor is located in the brain, this energy that makes it harder for the cancer cells to grow and divide. And the use of that device, along with the 6 months of chemotherapy, has been shown to have a modest improvement on average for patients. It's not a home run. And it unfortunately, although it has some benefit, as I mentioned, for most of these therapies, it helps most patients. The amount of benefit and the durability of the benefit is the issue, and the tumor has a likelihood of coming back. It did become approved by the FDA. It has little to no side effects other than the kind of factor of having to apply it directly to the scalp
Yeah.
and having it applied for 16, 18 hours minimum per day, 7 days a week for those 6 months. What I refer to as kind of the nuisance factor for patients to have to put up with for that. Um, but if they're willing to do that, and the studies have shown a modest improvement in survival, patients on average live um, a little longer, not a dramatic amount longer. So that is approved by the FDA as a standard that can be added in. It's really up to patients. I leave it up to our patients and families whether they want to use that and put up with that. A lot of them opt not to because it's just a bit much for them to deal with day in, day out. But the device has had some modest success and benefit, and if patients and families are willing to put up with it, it could help them do better for a period of time.
Certainly. Thank you again for that overview of standard therapies and also for highlighting the limitations that these have. And we explain this to patients that we know that these treatments help, but we know that they're not a way to eradicate the disease completely or keep it at bay for a prolonged period of time. And we're very grateful for all the research that you do in the area of immunotherapy. And I have a lot of questions that I would like to discuss and to help inform the audience about this. But why don't we start at the beginning and perhaps you can give us a very brief overview of the immune system and particularly its role in controlling cancer.
Sure. So, immunotherapy refers to utilizing our body's natural defenses, the immune system, to try to successfully attack cancer and eradicate it. Um, uh, this has been a holy grail that the oncology community has pursued for decades, for many, many years, and unfortunately with little success up until the last 10 years or so. And based on research, and again, coming back to this important theme of how important the research efforts are to better understand what gives these tumors a growth advantage, the research has identified a number of factors that the tumors use to protect themselves and to avoid the immune system. We call that an immunosuppressive effect, where the tumor actually is turning the immune system off, like flipping a switch and protecting itself. And the research has identified a number of these factors that the tumors secrete and generate to protect themselves. And with the identification of those defense mechanisms, treatments were developed, and many of them were actually pioneered at the Dana-Farber by my cancer immunology colleagues. And these treatments designed to overcome the factors the tumors have put in place to protect themselves have been remarkably successful. And you mentioned the immune checkpoint inhibitors when in your kind of opening comments, Dr. Gonzalez Castro, and that's the main area of immunotherapy where these approaches have transformed how we treat many cancers today. Many cancers have proven vulnerable to these treatments, and immune checkpoint therapies have now replaced, in some, not all, but some cases, chemotherapy and radiation as a first line of therapy. And those treatments now can be backups if the immune system approaches are not working. Unfortunately, not all cancers respond to these treatments. And there's a lot of interest in other immunotherapies like cancer vaccines, where we design a vaccine very analogous to the flu shot or the COVID shot that is trying to sensitize the patient's immune system against the cancer cells rather than against the flu or the COVID like those vaccines do. In this case, the vaccine is designed to sensitize the immune system against targets of the tumor. In addition, there are what we refer to as cellular therapies like chimeric antigen receptor T cells or CAR T cells, where the immune system cells are removed from the bloodstream from patients and then they're engineered in the laboratory over a matter of a few weeks to be able to specifically target markers on tumors, on the patient's tumor cells And then those engineered T cells, the CAR T cells, are infused and given back to the patient. And once they're in the body, they migrate through the bloodstream and they seek out their target and they identify it within the tumor and can theoretically successfully attack that tumor because of how they've now been engineered. The CAR T cells have revolutionized now how we treat many leukemia and lymphoma cancers, and been remarkably successful, even amongst patients who've had many, many rounds of treatment. These therapies have been remarkably effective. For many of the what we refer to as solid tumors, like brain cancers, these cells have been these types of therapies have been more challenging because the targets on the solid tumor cells are more heterogeneous and varied, and the tumor cells protect themselves, as I mentioned earlier, with a variety of different strategies in the microenvironment of the tumor, that even if we have these cells that are engineered to attack the tumor already has in place a variety of different mechanisms it's utilizing to fight off these types of therapies. So we're learning more and more about how tumors are doing that, how they orchestrate these different factors, and then trying to build our therapies to overcome them. But there are a variety of different types of immunotherapy, as I've tried to outline here. The immune checkpoint inhibitors, these are typically infusions, intravenous medicines that are given every couple of weeks to patients that help block some of the factors that tumors utilize to protect themselves. The vaccines that sensitize a patient's immune system against targets within the tumor, and then the cellular therapies, which are immune system cells naturally present from the patient that are taken into the lab, engineered, and then given back to the patient to successfully attack the tumor. So there's a lot of exciting work going on, a lot of different possibilities and potential combination strategies that we're trying to move forward and work with, to be able to tap into the potential of these therapies for our patients, because we've had a glimpse from many other types of cancers where these therapies have been successful about their successful potential and what they can do in the right circumstances. So our task, our challenge is to better understand what's going on with these glioblastoma tumors and how we can overcome what the tumor has put in place to protect itself and utilize these immunotherapy approaches to their potential.
Thank you for that overview, Dr. Reardon. You have made major contributions in evaluating immune checkpoint inhibitors in glioblastoma. And perhaps we can delve a little bit deeper, and you can tell us about the different classes and what we have learned so far about single use, combination use with other immune checkpoint inhibitors or with other therapies, and what's in the pipeline there.
Yeah, so these immune checkpoint inhibitors, as I mentioned, have transformed how we treat many cancers now. It's very exciting. And by the way, the work that we're doing here and the work that I'm a part of is very much a team effort here. And I couldn't do this without all of the wonderful members of our team, our scientific researchers in the laboratory, our clinical researchers working side by side in the clinic, our nursing staff, our clinical research team. It really takes a village of very dedicated and hardworking people to move these things forward. But immune checkpoint inhibitor therapy has revolutionized how we treat cancers. And these are medicines, people may be familiar with Opdivo or Keytruda. You see them advertised on TV now a lot. They're the leading drugs because they were the first of the class of these agents to come forward. But there's many more that are coming along, each designed to block a particular factor in the microenvironment of the tumor that the tumor is exploiting, taking advantage of to give itself protection against the immune system. And when we can take that away from the tumor, it then opens the door, if you will, and allows the potential for the immune system to be able to come in and successfully attack the tumor. And that's how these drugs typically work. Metastatic melanoma, a type of cancer of the skin, is, I think, highlights the remarkable achievement and potential of these class of therapies. Metastatic melanoma for decades has been a cancer that has been completely refractory to every type of treatment, radiation, chemotherapy, biologic therapies. If a diagnosis was made, patients typically died within 6 months of diagnosis. And my mother-in-law, who's in her 60s, was in fantastic, amazing health and had ended up getting an X-ray for some back pain and having, which ultimately noted lesions she was asymptomatic from, that ended up being melanoma in her liver. And despite the best available treatments, this was unfortunately just before immunotherapies were discovered. She, like everybody else who was diagnosed with melanoma, even though we tried chemo and other treatments, she died within 3 months of that diagnosis. And now we have, with immunotherapy treatments, upwards of 50%. We still have plenty of room for improvement, please don't get me wrong, but going from a diagnosis that was uniformly fatal within 6 months to now being able to cure 50% of patients because of the utilization of these immunotherapies has been a remarkable achievement, and I think speaks to the potential that we all hope these agents and these drugs are going to be able to achieve for every type of cancer. Some cancers are more susceptible and vulnerable than others, and it turns out melanoma, although it's refractory to just about everything else, this is an Achilles heel or a weakness for melanoma tumors, at least some of them, where the immune system can successfully attack with the right regimen of therapy. So the immune checkpoint inhibitors, with the success that was seen with this disease and now being applied across others, and these drugs like Opdivo and Keytruda are now approved by the FDA for more than 15 different types of cancer, have really been remarkable and, as I said, transformed how we treat many cancers. Unfortunately, some cancers, glioblastoma being one of them, pancreatic cancer, ovarian cancer, some types don't respond to these drugs. And we are working to better understand why that is, and we're making progress in better understanding that. And with that understanding, I think being able to move in additional directions where we can utilize immunotherapies to overcome the challenges that glioblastoma tumors put in place for our immune system.
Thank you for noting that these are drugs that have a lot of promise, and we're still trying to work the best way to use them in our patients in different combinations. And also you alluded to some of the obstacles that these immune cells have to overcome to really kill the tumor cells. And perhaps you can elaborate a little bit more on that. What other cells are there that are keeping these T cells unable to clear tumor, and perhaps some things that we do to help our patients to improve symptoms sometimes keep them from getting the most benefit from these therapies?
Yeah, the research that is being done now is trying to better understand what the tumors, how certain tumors are able to protect themselves and not be targeted by these immunotherapy drugs. And some of it relates to some of the answers we know are from factors that are secreted by the tumor that are at a high concentration in the bed of the tumor that can turn the immune system off or suppress the immune system, different cytokines and chemicals the tumors can utilize. And some cancers like glioblastoma also recruit in additional cells. They're not cancer cells. They're normal cells of the body called macrophages that they secrete, that they attract into the tumor, and these cells become transformed where they no longer function normally, but they're kind of reprogrammed, if you will. They're brainwashed, if you will, to be able to function to protect the tumor. The tumor has various strategies that it not only attracts these cells in to the microenvironment to protect the tumor cells, but then reprograms them. So they're like an army, if you will, protecting the tumor and the tumor cells. So we're learning more and more about how those cells work, how they protect the tumor, how they get there in the first place. And I think once we crack the nut on those understandings, and are able to effectively block either those cells from migrating in or block their protective function, I think we'll be able to open the door, at least part way, for immunotherapies to have an effect and a success in glioblastoma. And that same type of strategy of attracting in these protective macrophage cells is also something we see in other types of cancers that don't respond to these treatments as well. So we hope our research and our work will not only better understand this and hope ultimately be able to overcome this, but then also be able to have an effect for other types of cancers that aren't responding as well to these immunotherapy approaches. So although we still have a long way to go, and this is a very challenging feature of these tumors to better understand and be able to overcome, a lot of smart, hardworking people are focused on this, and I have no doubt we'll figure it out and we'll be able to overcome this in time.
Thank you. Do you want to say a word about steroids and the use of steroids and your thoughts? Because your own work has shown that these are helpful therapies, but that can limit the benefit of immunotherapy.
Yeah, no, that's a great point. And one that's somewhat unique to brain cancer because brain cancer causes a lot of swelling as the tumor is active and growing. It's an inevitable byproduct of the tumor, and that swelling is due to an inflammatory reaction in the brain from the tumor. And that swelling is what typically leads to symptoms, headaches, and neurologic deficits, and can even increase the risk of seizures. So to improve those deficits, improve headaches, improve quality of life for our patients, if we can decrease the swelling and that inflammatory reaction, patients will feel better. And symptoms related to the tumor will improve. Steroids, in particular dexamethasone or Decadron, is a very powerful, potent anti-inflammatory steroid medication that can decrease swelling in the brain by decreasing inflammation and can improve symptoms and deficits for patients, helping them feel better. And we've relied on Decadron for many years to help improve patients how they're feeling and how they're doing. It does nothing against the cancer. In other words, the cancer cells are still growing despite the anti-inflammatory effect of the steroid medication. It just decreases the associated inflammatory reaction and swelling. So even though the tumor is still growing and moving outward and invading and destroying normal brain cells, the inflammatory reaction is improved and their patients often will feel better. Unfortunately, the anti-inflammatory effect that is happening in the brain and improving patient symptoms also can diminish the function and capability of our immune system. So anti-inflammatory effects of these medications are not specific to the tumor cells and the tumor microenvironment. They can diminish the normal functioning inflammation and immune system function of our capability of our immune system significantly. And unfortunately, when that happens, steroids can impede or diminish the effectiveness of immunotherapy treatments because the immune system is not capable of responding as well. We're kind of tying the hands, if you will, of the immune system cells, so they're not able to be as effective in attacking the cancer by the use of the steroid medication. So when patients are on immunotherapy treatments, we do our best to limit the use of dexamethasone, in particular this potent anti-inflammatory steroid, in order to not interfere with or limit the impact of the steroid medication on the effectiveness of immunotherapy treatments. Unfortunately, that sometimes is not, we still have to use the steroids for severe or serious anti-inflammatory reactions and associated symptoms. And we don't have good backups other than steroids to achieve that goal. One medication many patients on the call and families may know of is Avastin or bevacizumab, and that can decrease swelling in the brain, not because of an anti-inflammatory effect, but its effect on the tumor blood vessels. And we do use it for helping to treat the tumors for our patients. That's the only medication other than the steroid medications, the anti-inflammatory steroid medications that can decrease swelling and improve deficits and quality of life for our patients. So we have, unfortunately, few tools to utilize to help with this aspect of the tumor and its impact on our patients. And the steroid medications and bevacizumab that we've had to use can certainly help, but the steroid medicine comes at a variety of different costs and side effects, one of which is its impact on the immune system and unfortunately making it more difficult for immunotherapies to work.
Thank you for clarifying that. Very helpful for patients to understand the two sides of the coin of steroids. Let's switch gears and talk about cancer vaccines, another area where you have been very active and have helped the development of new therapies. Can you give us a brief overview of cancer vaccines and perhaps describe the one that you're currently studying?
Yeah, so cancer vaccines, as I mentioned, for people to think about, very similar to the flu shot or the COVID shot, but in the case of cancer, we're giving this vaccine to sensitize the body's immune system and defenses against targets of the tumor rather than against a particular infection. There's a variety of different strategies that people have used over the last 20 years to try to achieve this with vaccine approaches. And some of them have been shown some pretty encouraging success. None of them are approved yet by the FDA, but they are showing some evidence of benefit for some patients. On one end of the spectrum, there is a very a type of vaccine that utilizes the entire tumor from a patient against or in combination with the immune system cells collected from patients. And this is what I'm referring to as something called DC-Vax. Patients may have heard of. It's been in the news, and some preliminary results have been put forward in the press showing some benefit, but some controversial results. And in this case, this type of vaccine was just a very general, broad strategy. The people who pioneered this just took the tumor, combined it with immune system cells from the patient, in other words, collected the cells from the bloodstream, had them in the laboratory, exposed them to the tumor in the laboratory, and then collected those immune system cells back and gave them back to the patient as their vaccine treatment. And the idea here is that somehow that exposure in the lab together would allow those immune system cells to find something in the tumor to react against. And then once they're given back to the patient, they would circulate through the body and seek out that factor and attack it if it's, assuming it's present within the remaining tumor cells in the patient. That's called a tumor lysate approach, where the whole tumor, just a gamish, a soup, a stew, if you will, of the tumor is exposed to the immune system. On the other end of the spectrum is taking advantage of the technology that's become available over the last 5 to 10 years, where we can understand what's unique and different about each patient's tumor. Again, looking at the genetic blueprint of the tumor cells and identify what's unique in patient, Mr. Smith's tumor and what may be different in Mrs. Jones's tumor, and then design a vaccine that's specific for each one of those patients by identifying 10 to 20 targets that are unique to their tumor that we can then include in a vaccine and give to them that may help sensitize their tumor against their sensitize their immune system against their tumor. The the challenge of this is that it takes a lot of highly technical, advanced scientific analyses to be able to identify these unique features per patient, predict the ones that are most likely to be effective in a vaccine, and then synthesize that vaccine and give it back to patients. We're doing that here as part of a program at the Dana-Farber led by my colleague Kathy Wu in the Cancer Immunology Group. And we're applying that type of a personalized, individualized vaccine on a patient-by-patient basis for not only brain cancer, but for kidney cancer and ovarian cancer and renal cancer currently, and leukemia, excuse me, as part of a institution, Dana-Farber institution-wide program. And that's a very kind of the other end of the spectrum where we're able to utilize this technology and take a deep dive in each patient and generate a vaccine unique and specific to that patient. What's given to one patient won't be able to help the next patient or the patient before them. It's really unique and specific to that patient. There are a couple of places that are utilizing the same type of technology. And one of these places is being run in Germany, and many of our patients and families have heard about this center that's trying to utilize a personalized vaccine approach. It is very similar to what we've been doing at the Dana-Farber for some time. I have to emphasize to patients and families these things, including our approach, are still very investigational. They're not proven. We have seen preliminary results where we can see the patient's immune system responding to the vaccine, which is encouraging. That's the first step. The vaccine has to stimulate the immune system. But then there's several steps that go on beyond that for that type of a sensitivity of the immune system to then be able to successfully attack the tumor. And those are complicated steps. And as I mentioned, there's a lot of factors the tumors are utilizing to protect themselves that even when we generate these responses, there's still an uphill battle for the immune system to very much overcome. But that's kind of, I hope, gives a sense of there's a lot in between of other different types of approaches. Another one that's been successful and looks promising for brain cancer is the Survivin vaccine, or Survax. Many patients may have heard of that or be aware of that. That's a vaccine that it's similar to our vaccine, but instead of focusing on 10 to 20 targets within each patient's tumor, this one focuses on one specific target. That target is expressed on multiple tumors of glioblastoma tumors. In other words, it's frequently present. So that type of strategy is working on a single target, but one that's important and present on many different types of many patients' tumors. And the preliminary results with that are encouraging as well. And we've been involved in the research that has been moving that forward for brain cancer patients. So there's a lot of exciting work. I could go on and talk about this in lots more detail, but just to give you a sense of the variety of different approaches and strategies that a lot of hardworking, dedicated teams are moving forward with. And we're hopeful these are going to continue to move forward for our patients and lead to some benefit and success. They won't, I don't think they're the answer by themselves. Any of these immunotherapy treatments at this point, after many years of work and effort, because of the complexity of these tumors, because of the factors they mobilize and put in place, there's a lot of differences and variety and heterogeneity and redundancy across tumors. That we're not going to find a one size fits all for everybody. We're going to have to mix and match and put things together in a combinational way that works when we put things together better than in an individual treatment alone by itself approach. And then I think going to have to figure out a way to do this on an individualized, personalized basis as well.
Thank you so much for outlining the landscape of cancer vaccines and for a wonderful overview of all aspects of immunotherapy. Um, let's take a few minutes now to answer some questions from the audience. And we had a couple that were sent in advance. As always, we encourage all questions. We cannot provide specific advice for patients. And if you would like that, we encourage you to seek a consultation at our center. But this question, for example, is from a patient that was diagnosed with glioblastoma, diagnosed 6 years ago in 2019. The patient tells that she has had three reoccurrences, and that as of recent has been on a regimen with daily temozolomide, the standard chemotherapy we mentioned at the beginning. And she says that she has been stable for some time with this and is wondering about what to expect with a regimen like this. Is it reasonable to continue on daily temozolomide for as long as her imaging is stable? What are your thoughts on this kind of a metronomic or extended temozolomide regimens?
Yeah, that's a great question. The chemotherapy drugs that we rely on, unfortunately, unlike other cancers, there's precious few of them that are able to successfully get into the brain. And that goes for other types of biologic therapies, other types of treatments. So treating brain cancer has a variety of different challenges, but one of the unique challenges is the protective mechanism called the blood-brain barrier that Mother Nature normally had put in place for us, which is an extra layer of protection in the bloodstream for potentially harmful things getting into the brain because it's such a sensitive organ. But that blood-brain barrier excludes the vast majority of cancer-fighting therapies that are my colleagues who treat lung cancer and colon cancer and breast cancer and prostate cancer, leukemia don't have to worry about because they don't have a blood-brain barrier to overcome. In terms of the treatments, very few chemo drugs penetrate through the blood-brain barrier, and the ones that do, we tend to rely on quite a bit. And temozolomide or Temodar is one of them, one of the few that does get into the brain through the blood-brain barrier. And the majority of patients will have some benefit with temozolomide chemotherapy. The problem, again, for most patients is the tumor, or nearly every patient ultimately will figure out how to become resistant and no longer respond to the mechanism of how temozolomide poisons the cancer cells and can work around that. But some patients, they evolve in their tumor that capability very quickly within a month or two. In other patients, it may take longer, and their tumor doesn't figure it out for a longer period of time. We also know that there are by using different drugs in different dosing schedules, their effectiveness can vary from patient to patient. There's no study that's shown a daily dosing schedule of temozolomide is better than the 5-day dosing schedule we typically use. In fact, that question was asked and a large study was run to answer that, and the two regimens giving the chemo 5 days in a row each month or every day at a lower dose for 28 consecutive days worked just as well. The percentage of patients who benefited was equal across the two groups. But there's variability from person to person, and in this individual, for reasons I'd love to be able to know and understand, her tumor has particularly been sensitive against that daily, almost continuous exposure of a low dose of the chemotherapy to hold it in check. That unfortunately has not been the case for many other patients, but in her case, that's the fortunate circumstance for her tumor. So unless she were having significant side effects, I typically would keep that going for a year or two. We do have to watch blood counts carefully with any chemotherapy, the normal white blood cells that fight infection, the red blood cells that carry oxygen, the platelets that protect us from bleeding. These normal blood cells in our bloodstream can be diminished. And if they drop from the cumulative exposure of chemotherapy, people can be at risk for complications from that. So continuing chemotherapy for 6 to 12 months is certainly very reasonable. And as I mentioned earlier at the beginning, in a subset of people where the tumors are showing unusual sensitivity, we may continue it longer. But it's always a balance between the potential risks and benefits here that we have to weigh out and evaluate on a patient by patient basis. But in her case, it seems like the benefits of continuing it would likely outweigh the risks for the time being.
Thank you so much for that answer. The next question is about glioblastoma. And the question is glioblastoma a low-grade glioma that becomes glioblastoma, or is it just glioblastoma? Does it first appear as a high-grade tumor?
What this refers to is the what we call the grade or the aggressiveness of the cancer cells when we study them under the microscope. And the less aggressive cells are what we refer to a low-grade type of glioma or cancer of the brain. And the more aggressive features of the cells under the microscope would categorize that tumor as high-grade or glioblastoma. And this is very much a spectrum. There's no, black and white demarcation from one to the other. But when the majority of the cells of the tumor that we're now analyzing under the microscope have a characteristic appearance of less aggressive features, that classifies as a low-grade tumor. We know those tumors arise in patients as a low-grade tumor, and they can continue and persist in the brain for years. At some point, something kicks those cells into gear and they can become more aggressive, and at that point become high grade or turn into a glioblastoma. That can happen. And that may happen after a few years or many years. And in some patients, it never happens. But unfortunately, for those who are able to have a successful treatment of the low-grade tumor, ultimately it can transform or become higher grade down the road. The vast majority of glioblastoma tumors arise in the brain as a glioblastoma. In other words, there was no preceding low-grade glioma that was growing there indolently for a period of time and then switched over and became a glioblastoma. Although low-grade gliomas can turn into glioblastomas, the vast majority of glioblastomas arise de novo as a glioblastoma, aggressively growing right from day one.
Thank you so much. And related to this question, next month on April 28th, we're going to have a webinar, IDH mutant gliomas, isocitrate dehydrogenase mutant gliomas. These are gliomas that often present as low grade and progress to high grade, as David highlighted, and we'll be providing more information on those then. So join us then. Another question that we have is about the fact that you mentioned that GBMs rarely metastasize, while some other cancers can metastasize into the brain. Are there any differences between the two, that you would like to highlight in terms of the metastatic potential of systemic cancers versus GBM?
That's an area where there's still an awful lot of research ongoing, and we don't understand, very frankly and openly, the reason why glioblastomas don't metastasize. They have all of the aggressive features of cancers that arise elsewhere in the body that can widely metastasize. But for some reason, there's something about their initiation and localization in the brain where they remain confined there. They're very infiltrative and destructive. So even though they're not spreading widely, they're causing, as our patients and family know, lots and lots of issues and problems. But for reasons we don't yet understand, I'm sure ongoing research and work that a number of my young colleagues like Dr. Gonzalez Castro are doing will ultimately lead us to better understand some of these mysteries that still remain about these tumors at some point in the future. But the explanation for that factor remains elusive at this time.
The next question is related to research, and the question is, I'll read it literally. In your opinion, is there anything you would recommend patients do to try to combat the recent cuts to medical research funding? I'm guessing that DFCI will be greatly impacted by these new policies.
Yeah, very timely question, I'm afraid. Um, this the current administration and how they're moving forward, very blanket-based strategies here is unfortunately going to have a devastating effect on a lot of the research that's ongoing. We apply very competitively for grants offered through the National Cancer Institute and the National Institute of Health for funding to support the critical research that's ongoing in for our for this type of disease, brain cancer. And with those budgets being slashed and held, a lot of the funding is at least being put on hold, if not being eliminated. And we rely on that funding to support these research efforts and programs. We're very fortunate. We have wonderful patients and families who and support mechanisms through philanthropy that help considerably as well, and we're incredibly grateful for that type of support. But the research that we work very hard to compete for and be able to ultimately be successful, 1 in 10, 1 of 20 or less grant applications. Even with that level of competitiveness, these are drying up and no longer being available. It's going to have a major impact, I'm afraid. Supporting any efforts in any way to try to raise awareness about this, the importance of this issue, and how it can have a critically detrimental effect on what's been remarkable progress that's been made over the last 10, 20 years in very difficult, challenging cancers like glioblastoma, really puts us at risk for breaking that momentum and losing hope for being able to develop the next generation of therapies and treatments.
Thank you for those comments, and I echo them, and I say that advocacy is important. So patients and caregivers and loved ones should bring up to the attention of their representatives that these are important issues, that we're working together to advance the care of very difficult diseases that will bring life, more life and better life to many patients. So we thank everyone that takes time to advocate for these efforts. One last question. What is the process for an individualized vaccine to be used on a Dana-Farber patient where an insurer is not covering for what the insurer considers experimental and not established?
So the individualized vaccine therapy that we have here is an example of a variety of different promising research efforts and investigational therapies that we're trying to develop through our research and through the pioneering work of the team and collaborators that are present within the Dana-Farber, within the Brigham, within our Harvard Medical School. Our network of collaborators is a remarkable environment here. These things typically, in order for them to be able to get to a point where we can give them to human patients, to patients in our clinic, have to go through a very rigorous review process and safety analysis that is very rigorously done here at the Dana-Farber and at most academic hospitals in the United States. To be able to get to a point where we can offer these things through a clinical trial. That process does require patients to be actively enrolled and participating in the clinical trial. In other words, I can't take an investigational or experimental therapy we're testing in a trial and just give it off the shelf to anybody in our clinic because of the way these clinical trials are rigorously reviewed and put in place to be carefully and safely administered for patients and families. There are very strict rules and guidelines through the Dana-Farber, through Harvard Medical School, through the National Cancer Institute, and through the um, uh, um, uh, other regulatory governmental agencies, and we have to follow those rules and regulations very carefully. We are audited and reviewed, as are other research institutions, um, routinely, and we have to demonstrate we're fully compliant with all the rules and regulations related to our research, including how the trials are conducted, which patients are treated, how they're followed, how their outcome is documented, and side effects and things, all of that very carefully scrutinized. So the bottom line is patients, we try to make these promising experimental investigational therapies available to as many patients as possible, but they are restricted in terms of their availability through the clinical trials that we're running and conducting. So I can only offer that approach, for example, with our personalized vaccine to patients who are able to fit the trial and able to enroll into the trial when there are openings available. This particular trial, as you can imagine, the work and effort that goes into each patient's vaccine treatment is incredible manpower and effort. As I said, it takes us about 4 months to make each individual patient's vaccine. So even if we wanted to or could, we simply don't have the manpower to offer this to everybody that we would want to. We do make it as available as possible, just like the other promising therapies we're working with in our clinical trials, through enrollment and participating in our clinical trials. So I'd encourage all patients and families on the call here to talk to their providers, talk to their team, find out what trials are ongoing, what they may be eligible for, what might be coming up in the next 6 months or down the road. If things change where they need to, may need to consider a different course of therapy, and what our clinical trial portfolio may be able to offer them.
Thank you so much again, David, for taking the time to answer all these questions and provide all this information for our patients. Many folks have benefited from this today live, and I trust that many more will do so once this is posted on our YouTube channel, on our website. So thank you so much again for joining us today. For everyone that joined us today, we ask you to please take a minute and answer the same survey you did at the beginning to see if the content we provided was helpful, and to give us any suggestions for future programming. And as I mentioned earlier, our next webinar will be on April 28th, and we'll be talking about IDH mutant gliomas. These are the second most common primary brain tumors in adults, and the most common in young adults, in folks in their 20s, 30s, and 40s. So join us today for more information on that disease. Thank you, David, again. And if you have any last minute thoughts for our audience.
No, I actually just wanted to take a moment and personally thank you, Dr. Gonzalez Castro. You're one of the leading stars of our brain cancer program, and you're doing great work in your laboratory research, and collaborating with many within our team and program. And I know you're also working very hard in the clinic, and for you to take the time and effort to put these important programs together with our team at the Dana-Farber for our patients and families is really a wonderful opportunity and resource for them. So I personally just wanted to thank you for everything you do, and for, in particular, helping with this effort.
Thank you very much.
Absolutely. Thank you, Dr. Reardon. Thank you, Dr. Gonzalez Castro. That was a great presentation. This will be recorded and posted on our Blum YouTube playlist, and shared with the Now team so that they can post it as well. But really appreciate you both being here today, and thanks for sharing your knowledge with us.
Thank you.
Bye-bye.